There we go. Good. Okay. Well, welcome to the Grand Rounds. Um, we are broadcasting live, and what we're going to do is I'll waffle for a little bit while we get people logged in and the attendees number up. For those of you that are logged in, just going to remind you that the Grand Round this week is going to be on acute pain. And we're very lucky to have Helen, Laycock and Glyn Williams talking to us about that. Remember, you can get the previous Grand Rounds via Gold on the internal link. And there's the Learning Academy YouTube channel as well, where you can freely get the Grand Rounds that have been previously been edited and posted up there. And we're getting quite a lot of people going to the YouTube and hitting on those. I think that some of them are only up to 400 views on that, which is really quite nice to know that we're getting out into the social media lines. Okay, remember to get CPD certificates, there's a Survey Monkeys survey at the end, and you can get a CPD certificate if you need it. If not, if you don't need a certificate, you can always self certificate for one CPD points from this. That's 45 minutes of teaching and 50 minutes of reflection. Good. Okay, well, enough of me. I think we're into a couple of minutes. We've got a fair amount of people joining us already, which is great. And we're on to a very important subject. I mean, it's something that's important to all of us. I think everyone experiences pain in their life, and it's something that probably is under-recognised and under-treated in children, I'd say. But that's just my personal opinion. But what I'd like to do is introduce the pain team, who are, of course, the experts on this, and I'm sure they'll let us know a lot more about acute pain with an update now. So over to Helen Laycock, who is currently our pain fellow.
Hi, thank you very much, Jonathan. So I'm Helen Laycock. I'm an honorary clinical lecturer in pain medicine at Imperial College, and also your current paediatric pain and anaesthetic fellow here at the hospital. So I'd like to thank the organisers for asking me to talk about acute pain. I always relish talking about pain. But when I was asked to give an update on acute paediatric pain, initially I thought, well, there's not a lot. We don't have any new drugs. And actually we've taken away one of the drugs we used to use until about 10 years ago, codeine. And to compound this, paediatric pain is under-researched, and a lot of our management strategies are extrapolated from the adult setting and adult trials. But as Jonathan said, it makes up a huge chunk of our daily practice, and whether we like it or not, a patient's pain journey is desperately important to their short and long-term outcomes. And I want to start by saying I'm exceptionally privileged to work in a fantastic pain team. This service was one of the first international paediatric pain services ever set up. Every policy document on acute pain and chronic pain seems to have at least one of our consultants, nurses, physiotherapists or psychologists involved in generating it. And for those of you new at Great Ormond Street, I'd really recommend taking advantage when you meet our clinical nurse specialists on the ward, because I know that they are experts in their fields, and I've learned a great deal from them in the last year since I've been here. But when I started here, I found it quite challenging, and I have a background in academic and adult pain. And the reason I found it challenging was I was in theatre seeing procedures I'd never seen before, and I had no idea what the operation entailed and didn't really understand what the post-operative course was, and I had to work out how I was going to understand and create pain management strategies for these patients. And that involved me really going back to first principles, and today what I'm going to look at is a framework for post-operative pain management, but really the peri-operative journey. And although it sounds very surgical, most of these principles can be applied to our medical patients as well. So the learning objectives from this talk I wanted to go through were just, what's the ideal peri-operative pain journey, revise the pain pathways and where the drugs work in them, and also think about how to develop a really personalised peri-operative pain management journey for our patients. And to start that, I think we need to think of the journey that paediatric peri-operative pain management has been through in the last 50 years. So it really starts off in '86 by a pivotal publication in Birth. There was then a policy document from the Royal College of Anaesthetists and Surgeons in 1990, and this was followed by the Declaration of Montreal in 2010, and a key document by the Association of Paediatric Anaesthetists in 2012, chaired by one of our consultants here, Dr. Richard Howard, that looked at peri-operative pain management for practically every paediatric pain procedure and also procedural pain. And finally, we come to 2020, where in the last few months, we've got a new definition of pain, which I think is pivotal to paediatric practice. And the key areas of development over these last 50 years have been the integration of acute pain teams, the use of patient-controlled analgesia, regional anaesthesia, and also enhanced recovery after surgery pathways. So why is paediatric pain important? Well, in the 17th century, we knew that infants and children felt pain. And then suddenly in the 18th and 19th century, because of our basis of scientific progression on Darwinian theory, that children were less evolved beings, suddenly it was felt that their nervous system was underdeveloped and they weren't able to respond to nociceptive stimuli in the same way as adults, and certainly couldn't process this to experiencing pain. So by the time we got to the 1980s, it was a sort of widespread opinion that children, and especially infants, didn't really experience pain in the same way as adults. However, this publication by Anand et al. Within the last year looks at all the scientific publications since the 1950s, and by using a bibliometric quantitative analysis technique, they looked at the citations of publications on infant pain. And what you can see is they increase from probably the 1980s upwards, and that's the top line, but the bottom line looks at when citations deviate from the median from the previous 2 years. And so what you can see with the peaks on the bottom line is years in which there are pivotal papers being published, and they started around 1986, 1987. And this really coincides with a paper, well, a letter published by Jill Lawson in Birth in 1986. It was written about her son Jeffrey, who was a neonate born at 26 weeks gestation, weighing less than a kilo, and he had a PDA ligation. And for that, he only received muscle relaxant. After his death, his mother reviewed his medical notes and began a crusade to improve anaesthesia and analgesia in neonates. And I'm going to read this out to you because I think it's really powerful. She said Jeffrey had holes cut in both sides of his chest and an incision from his breastbone to his backbone, and his chest was pried apart with an extra artery near his heart tied off. The operation lasted 1.5 hours and Jeffrey was awake throughout it. She, the anaesthetist, said Jeffrey was too sick to tolerate an anaesthetic, but anyway, it never been demonstrated to her that premature babies felt pain. Now, some can argue this is more about whether neonates should have anaesthetics or not, but actually I think it tells us far more about analgesia in neonates as well. And I think it argues really that neonates feel pain, and we then found in 1987 a pivotal Lancet study by Anand et al. Looked at a placebo-controlled trial of whether neonates receive fentanyl in addition to paralytics and nitrous oxide for surgery, and found that post-operative metabolic and circulatory complications were less in the group that received fentanyl. This paper has been acknowledged as one of the 20 most important papers ever published in anaesthetics. And this, alongside the groundbreaking work by Professor Mariah Fitzgerald here at UCL in neurodevelopmental pain pathways, made it very clear to us that infants and children not only experience pain, but they have physiological and psychological consequences of that pain. So the 1990 reports found that treatment after pain in surgery in British hospitals was inadequate and had been for many years and not advanced significantly. And there's a whole chapter on paediatric pain. And they start off by referencing a study from 1983 in Australia by Mather and Mackey that found that day one after surgery, 3/4 of patients experienced pain, of which 13% said it was severe. And then on day one of surgery, that increased to 17% of patients having severe pain. And they felt that pain management in children was difficult because of the same reasons as adults, but these were compounded by the fact it's hard to assess pain in children. At the time, they were using IM opioids. So I always think of this as pain to take away pain. So children were just saying they didn't feel pain because they just didn't want IM injections. And also at this period, we were using weak opioids predominantly, even after major surgery for paediatric pain. And when we did use any analgesics, we used them as at decreased doses compared to adults based on weight, not just on weight. They also reported that pain is a learning experience and influences future attitudes to medical care and pain. So we've known this since 1990. Usefully, the Declaration of Montreal by IASP in 2010 said that access to pain management was a fundamental human right and people shouldn't be discriminated against having access to pain management, and that includes discrimination based on age. I've mentioned a document in 2012 about procedural and post-operative pain management, and I would say that's probably the best up-to-date evidence we have on how to manage procedural and surgical pain for different surgical procedures. So where are we now? Well, it's taken over 40 years for the International Association for the Study of Pain to update our definition of pain. And on the face of it, it just looks like semantics. But actually, it's really important, especially to paediatric pain. So using the sort of phrase described in terms of such damage means that there's an assumption patients need to be able to verbalize that they're having pain for it to occur. So the change of the 2020 definition means that non-verbal children and infants, alongside non-verbal adults and also animals, can actually experience pain. This statement is associated with 6 other sort of smaller statements that are important to pain in general, 2 of them specifically to paediatric pain. So the first is that through their life experiences, individuals learn about the concept of pain, and I'll talk about this later. And also, alluding to what I've said already, verbal description is not necessary for people and infants and children to experience pain. So what about the prevalence of inpatient pain in paediatrics? Well, it's not really well known. Most of our data comes from single centre or nation-based studies. Taylor et al. In Canada in 2008 looked at 240 medical and surgical patients in their hospital and found that when they surveyed them, nearly 3/4 experienced pain during their hospital admission, of which nearly 1/4 reported moderate to severe pain at the time they were interviewed, and nearly 2/3 had moderate to severe pain in the previous 24 hours. And this has been replicated most recently in a study in 2014 in the United States, looking at 200 medical and surgical patients, of which 86% reported pain at the time of surgery, of which nearly 40% reported that as moderate to severe. I think it's worth noting that this is replicated in UK-based population studies. Whilst these predominate around adults, we know that the incidence of severe pain is around 20% in both medical and surgical patients, and notably, nearly 50% of those that express having severe pain had chronic pain as well. So we know that our patients are complex, their needs are complex, and pain exists in medical and surgical specialties alike. So what's going on in post-operative pain in sort of 2019, 2020? Well, unfortunately, we have no data on children. So we need to extrapolate it from adult data. And I think the most up-to-date available data is from PQIP, which is the Peri-operative Quality Improvement Programme led by the Royal College of Anaesthetists. Their 2017 and 2018 survey looked at about 6,500 patients in England and found that in the first 24 hours following surgery, nearly 50% of patients had moderate pain and nearly 20% of patients had severe pain. They highlighted that personalised pain management should be one of the top 5 national improvement priorities for peri-operative care. However, when they surveyed this again in 2018 to 2019, now looking at nearly 20,000 patients, again, nearly 20% of patients had severe pain in the first 24 hours post-operatively. So from this data, we know that 1 in 5 adults experience severe pain at their surgical site 24 hours following surgery, and we've got no idea what that prevalence is within children. We also know that from the 1990 document by the Royal College of Surgeons and Anaesthetists, their first recommendation was that pain should be assessed and recorded systematically. So how are we doing in paediatric pain? Well, the Canadian study I mentioned from 2008 found that nearly 3/4 of patients had no pain assessment documented in the 24 hours that they studied, and around only 20% had more than 3 assessments in 24 hours. What they did find is you were more likely to have pain assessed and documented if you were already being seen by the acute pain team and already on regular analgesia. The Boston study, whilst on the face of it looks a lot better because they found that nearly 100% had nursing assessments for pain, actually these were really inaccurate. Of the 40% of patients who had severe pain, what they found were half of these, when their pain was documented in their notes, it was documented that they had no pain. And that was just nursing documentation. When we look at physician documentation, less than 50% had documentations of pain at all in their medical notes. And when doctors did document about pain, less than 5% used validated pain scores in children. How are we doing at Great Ormond Street? Well, as part of a snapshot retrospective analysis of 30 urology patients who were admitted between May and October 2019, I looked at how we were documenting pain. And looking at the frequency of pain documentation, and this is major urological procedures where the patients had epidurals and PCAs running for 3, 4, 5 days after surgery, what you can see on the right-hand side is the decreases with each day following surgery. So that by day 4, nearly 20%, so nearly a fifth of our patients, have no pain scores documented at all in their EPIC notes, and this is not unique to this population. Snapshot audits by our pain team have shown this is common in medical and surgical patients alike. So what are the barriers to effective pain management in children if we know that the pain is under-recognised and under-treated? Well, the first thing I'd say is most analgesics are not systematically studied in children at all. What we know is they're often single dose studies. We don't have the pharmacodynamic and kinetic data for these analgesics being used in children. Often these drugs are used off-label. Also, we're trying to develop strategies that encompass the child across their childhood. So a neonate is obviously different to an infant, or a young child to an adolescent. Yes, we're trying to develop policies and protocols that encompass all these ages. And finally, what are we actually looking at as outcomes? I think pain intensity is exceptionally useful to evaluate, to look at trajectories and how each individual child is doing. But far more importantly, we should be looking at patient-based outcomes. The PQIP report kind of coined a term, dreaming. And all dreaming is whether somebody is drinking, eating, and moving after surgery. And I think it's very relevant to our patients. You know, are our patients functionally back to normal after surgery? And that's the real outcome of pain management as I see it. Interestingly, there's an international collaboration at the moment called PPOG, which includes a number of our clinicians from this hospital, that's trying to develop core outcome sets for infants, children and young people that's tailored to paediatric surgical outcomes and that population. And in their recent systematic review of how currently we're looking at outcomes in surgical populations in children, what they found is we often look at comfort, but actually we use a range of different endpoints with a range of diverse sort of periods with which we analyse it, normally only in the first 24 hours after surgery. And I don't think that's really relevant to our patients who have pain for days prolonged after we actually operate on them. So if we're going to think about pain management, what are our actual aims? And I think there are 3. The first is to alleviate immediate suffering. We know that pain is not only associated with quite well-known common physiological consequences, but there are also psychological consequences from acute pain. So a neat study from this hospital published in 2012 found that actually when patients had acute pain within their medical procedures in hospital, this predicted them to have poor behaviour in the first 2 to 4 weeks when they've been discharged home, with an odds ratio at 2 weeks of 8.2. We also know that poor pain management in hospital can lead to poor pain management in the future. And I think that's quite important. When we look at work by Noel, who's a Canadian professor in psychology, we know that memories of pain impact on pain that's experienced in the future. And your pain memory isn't like a tape recorder. So you don't just play it back. You actually have a negative bias if you've had significant pain previously. And so what that does is increase your anxiety, increase your bias, and increase healthcare avoidance in the future. And that's from infants from non-verbal infants through to adolescents. The other aims of our service are to return patients' normal function, as I've mentioned, and also within peri-operative care to reduce the risk of chronic post-surgical pain. So what I would say our ideal peri-operative management journey is firstly pre-operative assessment. So can we predict those that are going to have poor pain acutely after surgery and plan for that beforehand? And for our medical patients, it's predicting those who we expect to have poor pain management when they are admitted to hospital. And then intraoperatively, I think we need to think about using our pain pathways to guide true multimodal pharmacology. And then post-operatively, how do we assess pain? How do we manage pain? How do we discharge our patients on pain medications? And how do we follow up those for which pain continues after they've been discharged home? So firstly, thinking about those at risk of poor pain management, well, we know that those who have chronic pain and are on opioids when they're admitted are more likely to have poor acute pain management after surgery. There's a neat study of about 23 sickle cell patients that found that those compared to children who did not have sickle cell and did not have preoperative opioid requirements, when they underwent laparoscopic cholecystectomies, they had double the amount of opioid use, double the duration of PCA, length of use, and also had increased pain scores and increased use of adjuvant pain medications during their hospital stay. We know that certain surgeries are associated with chronic post-surgical pain, and also surgeries that have increased duration, where their surgical approaches are slightly more traumatic, are going to damage nerves, or at increased risk of inflammation at the site of surgery, all predict a poor pain management post-operatively. Also, those who've previously had poor pain management and those who are anxious about what the pain's going to be like after their surgery. I think when we're planning, the first thing is some of our patients come in on opioids already. Not many, not as many as in the adult setting, but there are those. And the first thing that one wants to do is to think about what their opioid load is. The Association of Pediatric Anaesthetists in America have some 2019 recommendations that say that the dose of opioids they have in the community before they come in, before their surgery, is their baseline. That's what keeps them on an even keel. We're suddenly going to give them a surgical insult, and so therefore they're going to have increased pain. So not only do they need the amount they have in the community, but they're going to need increased doses to account for that surgical input. In those circumstances, the acute pain team needs to be involved early, possibly before they've even been admitted to hospital. But for everyone as a clinician, it's useful to think about how much opioids they're actually having. And what I do is convert them into what it would be equivalent in morphine daily. So what's their morphine in milligrams of oral morphine over 24 hours? And there are some useful conversion charts. I've given the web links for there, which generate apps. There's one from the CDC and one from Australia. Now, bearing in mind, these are adult conversion charts. There are not pediatric conversion charts really out there. And so these have been tested in healthy male young volunteers. But what they do is give you a ballpark of what that patient is on. Because I think what worries me the most about these individuals is when they come in for surgery, are we actually going to give them less than they have in the community? And are they going to withdraw, which is a significant life-threatening complication? What other non-opioid analgesics are there on? Can those be stopped when they come into hospitals? Should they be stopped? And that's not just gabapentin, pregabalin and amitriptyline. It's things like regular ibuprofen and naproxen use. As I've said already, the inpatient team needs to be used early, and that's the whole NDT, so our physiotherapists, our clinical nurse specialists, and our psychologists. And then how do we educate our patients before they come in? We give them lots of information about what to expect. Is pain management integral to that education? We know for some information of quality improvement projects in British Columbia, published in the last year, that actually not a lot of complaints happen in peri-operative care, but the majority of them, over 90%, involve poor post-operative pain management. So how are we educating our patients on what they need to expect? And are there quality improvement projects that can really improve expectations and information about how we manage care post-operatively? As far as chronic post-surgical pain, this is pain that develops or increases in intensity after surgical procedures and persists beyond the healing process, notably normally after 3 months as far as the ICD-11 new definition is concerned. We know in paediatrics there's not that much data, but it seems to be around 20% for mixed major surgical procedures, but ranging anywhere between 11 and 60% depending on what surgery is being performed. We've got a lot of data in the adult setting, and not all of those translate to risk factors in paediatrics, but certainly pre-surgical anxiety, parental but not child pain catastrophizing, so that's when you're sort of desperately worried and anxious about the pain you're going to experience in the future, and also poor pain coping efficacy in the child themselves. Notably in the spinal population, there's some evidence that pre-existing pain might predispose to chronic post-surgical pain, but that's not clearly understood, and there is conflicting evidence on that. But what I think we really need to be thinking about is personalised pain medicine. And with that, that's the holy grail, but there is the caveat that no perfect drugs or drugs exist. And at this point, I think it's important to think about our pain pathways when choosing drugs. So in simple terms, our pain pathways include direct or indirect activation of primary sensory neurons that generate action potentials. These are then transmitted through the dorsal root ganglia into predominantly Rex lamina 1 and 2 in the spinal cord. These synapse with second order neurons and either project along those red pathways up into the thalamus and higher cortical centers, or involve second order interneurons that modulate pathways within the spinal cord. We then have downwards modulation that's both facilitatory and inhibitory of these ascending pathways to change how the noxious input is interpreted in our higher cortical centers. That's a fully formed neurobiological pain pathway. But as far as infants and neonates are concerned, we know that by 7 weeks gestation, primary afferent nerve fibers innervate the skin and project to the dorsal horn and reach the thalamus. By 26 weeks, peripheral of gestation, noxious input can elicit responses in the thalamus and in cortical structures. However, in neonates, there's a bit more going on in that A beta fibers, so those that transmit touch, actually synapse at 26 weeks gestation within Rex lamina 1 and 2. And so what you have is touch stimuli actually stimulating those second order pain pathways as well. And they don't really die back from there until your C fibers are matured, which is later on in development. Furthermore, we know that descending inhibitory tracts are not fully developed until post-term, and actually not developing full maturation until sort of late childhood, early adulthood. So preterm infants sort of have underdeveloped, underdamped, poorly discriminative, sort of afferent upgoing stimulatory pathways, and then they don't have this kind of dampening down of the descending inhibitory pathways, and so they often have an exaggerated response to noxious stimulus. And what are our aims of pharmacotherapy? Well, it's really thinking about that pain pathway. So we're decreasing those ascending pathways and increasing the inhibition that occurs in either the spinal cord or our descending pathways. Within that, we want to decrease sensitization of our nerves, so increased firing and increased responses to noxious stimulus, both in the periphery and in the central nervous system, because we know that and wind up at a spinal cord level. So that's when you have repeated similar size stimuli that lead to an exaggerated second order neuron response. And both of those are key in developing chronic post-surgical pain. So when we think about in the periphery, because I'm going to look at pharmacology in all of these three areas, in the periphery, firstly, local anaesthetics and regional anaesthesia makes complete sense. If you're blocking those incoming signals, you're not getting signals up to the higher cortical centres. And we've known that since the 1990s, and it was recommended in that 1990 Royal College of Anaesthetists document. Excitingly, the International ERAS guidelines for neonatal intestinal surgery that were published in May of this year have a strong recommendation for the use of regional analgesia, even in neonates. And they reference sort of studies on tap blocks that show that opioid requirements and associated side effects such as sedation, nausea, and gastric motility issues with opioids are reduced if regional analgesia is used. Opioids actually work in the periphery as well as in the central nervous system, but I'll talk about them later. Non-steroidals and COX-2 inhibitors are known to be very effective in treating mild to moderate pain in children. And actually, a systematic review from about 7 years ago by Wong et al. Demonstrated that they have significant opioid sparing effects and actually reduce PCA usage by around a third. We know that they're fairly safe in children for short-term use, and their risk of gastric irritation is low, and in the same magnitude as actually that associated with paracetamol. Risk of acute kidney injury and renal failure is lower in children than in adults and in rare. And as far as bone healing, which is often a controversial topic with their use, certainly in the paediatric population, there's limited data. But if you look at spinal surgery and fracture and osteotomy care, there's only small studies out there, but they suggest non-steroidal use is not associated with increased risk of repeated surgery or delayed healing or non-union of bones. And whilst there's limited data of use of coxibs in paediatric care, certainly their use within juvenile idiopathic arthritis is reassuring in their sort of safety profile. As far as steroids are concerned, there's an increase in interest in this at the moment in the adult sort of acute pain population, but there's little evidence for their use in paediatrics. The 2011 Cochrane review of tonsillectomy care did suggest that dexamethasone use was associated with decreased pain scores, but I think the jury's out about whether they're really associated with improved analgesia after operations. As far as spinal cord sort of ascending pathways are concerned, this is where the bulk of our medications work. So central neuroaxial blockade, just like regional anaesthesia and analgesia, kind of makes sense. It's blocking the pain pathways going up. As far as paracetamol is concerned, their mechanism of action is questioned. They might work centrally on COX inhibition. They might work on descending endocannabinoid, serotonergic and NMDA receptors. But what we do know is there's strong evidence to support their opioid sparing effects in children post-operatively, and also they're included in those ERAS guidelines I mentioned for neonatal surgery, for intestinal surgery in term neonates. Obviously their dosing in neonates is completely separate and a talk within itself. I think there's real tension about opioid use at the moment in acute pain, and certainly in the adult setting, we're really worried about their use, and it's a shame because it's really the gold standard that we have for paediatric severe pain. Morphine is our gold standard opioid. However, actually, all opioids work equivocally if they're used at the appropriate dose. We know opioids are exceptionally safe in the paediatric population, especially when used with NCAs and PCAs, and that's through over 20 years worth of data that's been published multiple times from our patients here in this hospital. We know that life-threatening adverse events from NCA and PCA use is around 0.4%, and that's greatest in the neonatal population rather than in older populations. Tolerance and withdrawal is something that you really need to think about, and I've mentioned that already, and that's why we often rotate opioids for longer opioid use in our acute care. Ketamine's an NMDA receptor non-competitive antagonist, and it works predominantly by blocking ascending transmission. One-off doses of it are very useful intraoperatively in reducing post-operative opioid use, and we use it and have a great wealth of sort of evidence and also experience in using it post-operatively and also in our medical patients within PCAs as opioid sparing, and it's a great extra analgesic medication. Pregabalin and gabapentin sort of have come into fashion a bit more, and that came about from gabapentin potentially reducing chronic post-surgical pain in adults. Actually, if you look at the more recent systematic reviews and meta-analyses in adults for both of these drugs in acute pain, the evidence is controversial. And I think we really need to think about, in acute pain, what we're using these medicines for. Are we using them as opioid sparing? Do we think that they actually are an acute pain medication within themselves? I think they have a great place for phantom pain, for acute neuropathic pain. But as far as acute pain in general, their blanket use, I think, is questionable. And we have very little data on their safety for that in children. I think it's important to note that their side effect profile is significant. Adolescents tolerate this really poorly. Weight gain, fuzzy feelings, decreased concentration is significant. And also, there's some evidence now that they are associated with increased risk of suicide and suicide ideation. Specifically, the last cohort-based study, population study of over 200,000 individuals in Sweden, found that in the 15 to 24-year-old age cohort, the use of pregabalin was associated with increased suicidal behaviour. And I think it's important to remember as well that if we're starting them pre-operatively or during the kind of acute post-operative care, they actually take a number of days of pregabalin and a number of weeks for gabapentin to actually reach therapeutic thresholds. So their use needs to be really thought out and carefully considered. Clonidine, an alpha-2 agonist, has both nociceptive transmission inhibition and also decreases the risk of substance P, so decreases that sort of inflammatory process going on around our neurons leading to inflammation. It's got a long history of use of paediatrics, and the last Cochrane review on its use found it was associated with decreased pain scores. Magnesium and IV lidocaine are more intraoperative drugs, and I'm not going to dwell on them today, but their evidence is coming through about whether they're useful in paediatrics. As far as descending pathways is concerned, I've talked about most of these drugs already, but tramadol's kind of the main drug that we have that actually doesn't really work through opioid receptors. It's far more important action is via serotonergic and noradrenergic descending pathways. Its safety profile and pharmacokinetic profile are similar to that in adults. And what you do get is poor, normal, extensive and ultra metabolizers, just like you see with codeine. So that's something to bear in mind when we prescribe it. The last Cochrane review in 2015 felt it was as good as opioids for post-operative care. But an additional thing that one needs to think about is the polypharmacy that our children have and whether there are any other drugs that work on serotonergic pathways, because combined use can lead to serotonergic syndrome, which can be life-threatening. We can prescribe it for children over 1, and we have great data and instructions on its use on the pharmacology pages on the GOSH website. And finally, something for the future is tapentadol, which works in a similar fashion to tramadol, but doesn't have the serotonergic effects. There's been a couple of acute post-operative pain papers come out, which were open label in the last couple of years from Switzerland, which show that its safety profile seems good in children, and the analgesic effects seem quite advantageous, but I think the jury's out at the moment on its use in paediatric care. So as far as prescribing, what should we be doing? Well, we should use a 2-step ladder, so simple analgesics and then stronger or adjuvant analgesics, and that's WHO recommendations for paediatric pain. I would say if we think our children are going to be in pain, we need to think about round-the-clock prescribing. So are these analgesics prescribed regular? By all means use strong opioids for breakthrough pain, but regular paracetamol and ibuprofen are important, and we don't use them enough. If we don't prescribe them regularly, what you get is this sort of boom and bust in kinetic and pharmacodynamic consequences, which mean our plasma concentrations change variably throughout the day and night time, and we don't get effective analgesia. Think about our patient's age, what are the appropriate routes for analgesia, and also the child as an individual. They often know what pain medications suit them and what don't, and we need to take that into consideration. So something I want to spend a few minutes talking about is true multimodal analgesia, and that's not just the pharmacology. We know that integrating rehabilitation and physical therapies, psychosocial interventions, spirituality, and other things act synergistically to sort of work with the medications that we give to give good analgesia. I've already mentioned that anxiety, depression and pain catastrophizing can lead to chronic post-surgical pain, but these methods are outside the realms of this talk, but they're also very important in acute pain management, and psychological therapies are really thought to decrease pain intensity and opioid consumption within the acute setting. Our physiotherapists here are phenomenal, not just the pain physiotherapists, but our physiotherapists who work within the surgical specialties and the medical specialties, and their integration into acute pain management and rehabilitation is really key to getting our patients back to their functional normality. I think spirituality, patients and parents' sort of life goals are important to consider in their pain management. And what other things can we use? From infants, it's things like kangaroo care, breastfeeding, sucrose, swaddling, to heat packs, ensuring our patients have social integration. Our pain therapists are brilliant at being advocates for our patients and also reducing the pain they experience. And there's a whole host of other medications that really make pediatric pain multimodal, not just in its pharmacology, but also in all the approaches that we use. I've talked a little about assessing pain. I think we need to think about what we use, when we use it, and how we respond to those pain scores. It shouldn't just be at rest, it should be on movement. And also we should be thinking about our patients' kind of return to functional activity. So as I mentioned before, dreaming. I've listed the pain tools we use here in the hospital. They're on Epic. They're desperately easy to use. They show you how to use them when you click on each box, and I would encourage people to use them every time they assess patients. And as far as discharge planning is concerned, I think we need to think about what drugs we have, when we stop them. Do we give instructions to our GPs on what drugs to continue, how to taper them, how to stop them? There was a lovely poster at the Acute Pain Society a couple of years ago that looked at adult patients who were on gabapentin who got sent home, and less than 5% of them had any instructions on how to taper that medication for their GP once they went into the community. I think we need to think about who monitors our patients when they go home, and how do we pick up those who have chronic post-surgical pain or potentially complex regional pain syndrome after surgery, and how do we refer them into transitional clinics or chronic pain clinics? And also, do we have the resources available to think about how we manage these patients in the long term? So what's the future for pain management? Well, I'd love to say it's a new drug. I don't think it is. Sea snails from Australia haven't quite generated the sodium channel blockers that we thought they were going to. And also venom from spiders from Brazil that block calcium channels haven't quite translated to clinical care and efficacy within clinical trials yet. I think the real future is how do we predict those that are going to develop chronic post-surgical pain, especially in paediatrics. We don't have a lot of evidence on this. Genetics is an easy one to throw into what the future is, but specifically with regards to pain medicine, thinking about specific opioid receptor genetics. Are there patients who have specific polymorphisms that mean they are less responsive to opioids or are more at risk of acute post-operative pain? And looking at COMP genes as well. Can they predict problems with acute pain post-operatively? And then finally, how do we assess pain? At the moment, self-reporting is the gold standard, or we've got some sort of observational tools, but actually objective assessment, so things such as heart rate variability, pupillary light dilatation, and skin impedance haven't quite translated yet to clinical care. But can we objectively assess pain in our patients to mean that we can treat pain more effectively in the future? So I'm going to go back to what the ideal perioperative pain management journey is, which is preoperative assessment, intraoperative care, and postoperative management, really. And I'd like to leave you with, I think, the most important slide from today, which is the new updated definition of pain, which is desperately important to all paediatric clinicians and anyone who has clinical care for children, because we know now, and it's formally acknowledged, that children experience pain even if they can't express it verbally. And I'd really like to throw the stage sort of open to the Slido questions for Glyn and myself to answer, and hopefully this whistle-stop tour of acute pain has been enough to sort of whet one's appetite. Come and talk to us when you see us on the ward, ask us questions and ask us advice, because we're there to kind of help with these things.
Thank you very much, Helen. I don't know whether everyone can hear me. Yeah, Helen, keep your video on if you can.
Yeah.
And then you can, if you stop sharing your screen, that's it. We get Glyn up, so you can see Glyn as well, which is fantastic. Good. That was really interesting. It's something that we think about every day in anaesthesia, but it's really interesting to see it. I think expanded to the rest hospital as well. So there are a number of questions come up on Slido, and I sort of maybe I'll put them in just into sort of pre-op, pre-op out the hospital, pre-op when you come into the hospital, and intra-op and post-op sort of stuff from the pain point of view. Just sort of pre-op wise, when you're saying that, if you can personalise your analgesia plan for each patient, is there anything active at the moment? For example, people with high expressed anxiety, family backgrounds. Is there any behavioural elements that you can teach them that has been shown to decrease their pain scores or analgesia requirements during operations? And all these other things that you mentioned there, family dynamics and so on and so forth. Is it actually being assessed and done at the moment anywhere in the world, or are we doing that?
So there's, Glyn, correct me if I'm wrong, there's not a lot of evidence on it. I actually was looking at a paper in adults recently on, that hasn't been published yet, on psychological interventions that occur pre-operatively before adults go to theatre. And the evidence is scarce. The psychological interventions are wide and varied because psychological interventions are hugely diverse in what they encompass. And so it's the evidence isn't really out there, and it's a shame because they're quite easy wins for us to actually integrate into our sort of pre-operative journey for our patients. Glyn, I don't know whether there's anything specific in children that you know of.
So the team from Canada that you alluded to, Rabbits, have been doing multi-center studies in Canada for a long time on scoliosis patients, and that's where the predictors for persistent post-surgical pain have come from. And they're a group of psychologists who have been doing that, and they have got trials ongoing about putting in place psychological interventions pre-surgery, but they haven't been reported yet, so we're going to have to wait to see what that comes back as. But it is, it's well known about anxiety increasing pain levels in children. We've known about that for a long time, and but unfortunately nobody's really studied putting in place psychological techniques for trying to reduce anxiety in both the children and the families before they come to surgery. But you would have thought it would be quite a quick win if we could do it, as Helen has suggested. But it actually comes down to the identification and then putting in the resources for that to be able to be done. So I think it's a big area that needs a lot of push forward, but it does need the resource putting in place for it to happen.
Okay, and what about the sort of the pharmacogenomic differences in children? I mean, I think you alluded to that, and that's my understanding is that that's led to the ban of codeine in some centres or around the world. So, how far away are we doing a sort of genetic profile of children and whether analgesic requirements or metabolic status? I mean, we're doing it at the moment for the aminoglycosides in children coming in because there's a risk of hearing impairment, isn't there? So. Is that important? Is that somewhere we're going to soon?
So I think it depends on which. I mean, genomics is a huge area, and pharmacogenomics itself is a huge area. So there are some suggestions that a specific opioid receptor, I think it's ORM1, is associated with increased pain after abdominal surgery in adults, and I think that's as far as we've got. It's an area of huge expansion at the moment, of huge interest, but I just don't think the evidence of which polymorphisms are associated with increased pain are clear. And then as far as we're thinking about metabolizing drugs such as codeine and tramadol and any of the cytochrome P450 system drugs, again, it's about A, whether there's a test out there to do it, and B, will it change practice? Would I take codeine back into my armory of post-operative analgesia if I suddenly could work out who was an ultra metabolizer and I knew I could give it safely? The answer is no. Codeine, to me, somebody said on Twitter, it's like giving morphine, but you just don't know how much you want to give. And that's what codeine is. Like some people don't metabolize it. it's a prodrug anyway of morphine. If I'm going to give morphine, I want to give morphine. So I don't think it would change what I'd give at the moment, and I don't think it would potentially bring drugs back into fashion that have now quite rightly sort of gone out of fashion. Again, a bit like what we've said about the psychological interventions pre-operatively, it's a fantastic area of potential research. I think somebody could build a whole research career on it. I just don't think we know quite yet which polymorphisms are associated with what. Glyn, I wondered whether you had anything else to add.
Yeah, I mean, I think the extension of that is, when we talk about the codeine debate, is around the fact that it's, that's slowly going to seep through every other mild opioid that we use as well, apart from oral morphine, in the sense that the cytochrome P450 CYP2D6 is involved in their metabolism as well. And just to make people aware that tramadol has got alerts and bans put on it in countries such as America, Australia and New Zealand, similar to the bans that we now have on codeine. And the sort of logical extension of the way people are approaching this at the moment is that every single mild opioid that we use is slowly going to be banned as we switch from one opioid to the next one, as the last one is taken away from us. So we have to be careful about what we're doing there. And actually, genetic profiling, whilst I agree with Helen about bringing a drug like codeine back, which is a prodrug, it might help us in this situation sort out other medications which are metabolized in a different way or are not prodrugs, and allow us to decide which ones we can and can't use in certain patients. But the ability to have that test sort of at the end of the bed and available to us to be able to make those decisions quickly on the amount of patients that are coming through, especially day surgery type things, is quite a big ask, and I think we're a long way from that at the moment.
Okay, so moving on to pain scores, there's been some questions about pain scores. I mean, I think that people want to know what is the best pain score to use, and does EPIC choose the right one for you, considering the age of the child and the developmental milestones?
So EPIC doesn't. So you have an option of a number of different ones. Obviously, critical care and NICU have their own specific pain scores that they use. But if you're thinking about the ones we use in this hospital, it's an NRS or a FLAC. And I think it's not just about age, it's about the child's development, their ability to communicate. Because obviously self-report is the most reliable way of evaluating pain. However, there are many children who can't do that. So if you pull up your normal child, you could score them with a FLAC or an NRS. And actually, I've seen it with a number of sort of 10, 11-year-old patients at night when they're asleep, somebody's scoring them with a FLAC because they can't wake them up and ask them what their pain scores are. And I think it's completely appropriate not to wake them up. But actually, EPIC's very clear in what we can use, and we've got very standardised methods of what we should use in this hospital. Glyn, is there anything you wanted to add to that?
No, not really. I mean, I think, the ones that we use have been carefully chosen over a long period of time to be easily usable, easily educated between patients, and the right ones for different developmental ages. There'll never be one pain score that is right for all developmental ages across all clinical scenarios. So it has to be to pick the ones that you can use. But the sort of golden rule will always be that if a person can self-report their pain, that is the most appropriate pain score to use. But as Helen's pointed out, they have to be at the right developmental cognitive ability to be able to do that.
And is there any, just, people said, is there a way of making pain scores compulsory in EPIC? So it's like a hard stop, like, drug allergies or not that. So, because I'm sure people are missing medical patients or their own pain.
So we know that medical patients have less pain scores performed than surgical patients, and that's across the board, adults and children, nationally and internationally. I also think it's about thinking about what are we assessing, what we're using pain scores for, because actually I use pain scores for two things. The first is to identify a patient in pain, which is what you're talking about, Jonathan. The second is to work out whether the drug I've given them has actually worked and whether it's given them analgesia in the second place. And so there is a question about how often we should be doing pain scores. And how regularly they are recorded, even just as a blanket screening tool. And I don't know whether we have a consensus on that at the moment. I think I put on that graph, 4 pain scores, because I was like, that's a minimum of 2 a shift. That's not outside the realms of the possible. But I think it just, because I'm going to hand over to Glyn, but I think it's important to note as well, nurses do a lot of these pain scores, but actually it's the responsibility of clinicians as well, when they have an interaction with children, to also score children for pain at that point. And often clinicians deflect the responsibility of that onto other healthcare professionals, and I think we should also take it within our realms as doctors to do that as well.
I mean, yeah, I echo everything Helen says. Unfortunately, one of the failures of EPIC, and I don't know if other clinicians have noticed this, is that the amount of recording that is done at the patient's bedside is massively decreased since we've gone from paper to electronic. And so it's not just pain scores that are suffering, it's across the board in observations. And we've talked through, both through practice education and with EPIC, about this to try and make things better. But if there's anybody on this call who works for EPIC who can help us in this situation, because it hasn't been forthcoming up until this point, we'd love to chat to them. But certainly, yes, more accurate and more frequent pain scoring on EPIC should be there, and had the potential for not just pain, but for lots of observations to cause a stop on EPIC, so that people are actually recording them properly, is a very important thing that needs to be addressed.
Okay, good, that's helpful. A couple of specific questions. What about the dose of ibuprofen? Most of us prescribe it as 5 milligrams per kilogram 8 hourly, where the BNF says we can give up to 30 milligrams per kilogram in 24 hours, which would be, I suppose, double that dose, isn't it? What should we be prescribing, and do you think we're under prescribing it? Because Helen was alluding that it's much safer than we think it is.
Yes, short answer to that is yes, we are under prescribing it. It is 30 milligrams per kilogram. And in fact, if any rheumatology colleagues are on now, they'll be using doses much higher than that for their children going forward. So I think 30 milligrams per kilogram is a good dose, and we should be using it, and we should be using it sooner. I mean, one of the problems we do have that Helen alluded to is that the multimodal analgesia often isn't given on the wards afterwards, and the idea that we have to get these children eating and drinking before non-steroidals can be given again, and that wouldn't be our advice. Our advice would be that non-steroidals can be given right from the time of surgery through afterwards. And we would like the ability to be able to give other forms of either non-steroidals or coxibs on the ward, particularly IV formulations, and we hope that that's going to come through work with the Drugs and Therapeutic Committee, but at this point we haven't been able to do. But we should be using, non-steroidals are very good for post-surgical pain as part of an analgesic, multimodal analgesia regime. We know that they're opioid sparing. And so the more that we can get in at the correct doses, and the more regularly we can get them given, the better effects we're likely to see in the appropriate patients. Obviously.
Good. All right, so watch this space. So hopefully, I'm certainly going to change my practice from that. Thank you. What about alternative therapies like acupuncture, massage, and crystals, that sort of stuff that people have shown up?
Yes,
should we prescribe that? I mean,
Well,
it's harmless, is it?
We can prescribe it because we don't necessarily have the practitioners to be able to deliver it. I think for a lot of these alternative therapies, there is no evidence base behind them. But, what we do know, obviously, is for some people, they can be extremely effective. And they, you have to weigh up what you're trying to do and what the risk is. And for a lot of these, obviously, the risk is very low and there is a potential benefit. And so why not think about using them? There is becoming an increasing amount of evidence about how good TENS can be in the post-operative period. And that is maybe something that we should look to use more on our patients during that time. And our nurses are extremely skilled at TENS and can offer very good advice. And we have a large number of the machines that can be available. So that is something we look for on the pain rounds as to whether it can be of use. But equally, again, that for clinicians and nurses out there, if you think your patients may benefit from us using that, then please contact us and the nursing team, and we can make an assessment and give the machines and the education as appropriate.
And that's a perfect last question, actually, because we've run out of time, sadly. So, can anybody contact the pain team if they think a child is in pain?
Absolutely. Our bleep number is the same as it's always been, 0577. And okay. If that fails, which it shouldn't do ever, but if it does fail, the office number is 5940.
Great. And it doesn't have to come from a clinician or physician, does it? Come from nursing staff, anybody involved with the child. That's really helpful. Thank you very much, guys. That's a really good, very thorough update on pain. There's a whole load more questions I can ask you, and other people have got nice loaded, but I think we're out of time.
If there's any questions, obviously people absolutely please feel free, send them through to the pain service or send them through to Helen or me, and we'll be quite happy to help.
Brilliant. Okay, we will certainly do that. Thank you, you two. That is really interesting. So I'll have to wrap up now, I'm afraid. So thanks you guys for that grand rounds. It will be available on Gold and YouTube as soon as we can edit it and get it up there. If you want a CPD certificate, please follow the SurveyMonkey link, which is coming up. Give us some feedback and we'll give you a certificate. And our next grand round is coming up in 2 weeks' time. It's going to be the ICT team looking at our internet security and how we can keep ourselves safe online and away from all the phishing emails and so on and so forth. Good. Okay. Thank you very much. And we're done.